Hello, everybody. Are you there? Is anybody there?
Yes, sir.
Welcome. Yeah, there. That's good. Okay, we start in 15 minutes.
Hi, John.
Hey, Samer.
Hi, how are you?
How you doing?
I'm okay.
Okay, everything set up okay?
Yeah, hopefully, yeah.
See, anybody special? Let's see, I'll make you co-host.
Okay.
So that, oh, you're not in yet. Okay, let me get you in here. I don't think you're in. Are you in, Samer?
Sorry?
Are you in the panel now? I don't see you.
No, I don't think I'm in the panel.
Oh, there you are. Okay. There you come. Okay. You get in okay?
I hear you clearly.
Okay, is there anybody I need to admit? You can admit the people from in the panel.
Yeah, sure. I will.
Yeah, go through that. You see, admit the ones you want to admit. Can you see? Make sure you can do it. Let's see you try it.
Yeah, I'll try now.
Yeah, you go to the right, then you go to the three dots. Open that up and then promote to panel.
Yeah, I'm searching for people I know.
Yeah, see what ones you want.
Actually, I don't have this option.
Oh, you
Yeah.
don't? Okay, let me. Okay, maybe I didn't give it to you. Let me check.
Okay.
No, I didn't. Okay, I didn't. Okay, now you should.
Yeah, co-host now. Let me try promote.
Okay, do you see where you admit? We go to
Yeah.
three.
Yeah, I already admit few people. I want to see what is the others.
Hello, Zanab. So did you get the people in that you wanted to get in?
Yeah, some are not logging yet. Hello, Zainab. Zina is there. Zainab.
Hi,
Who
Dr.
are you looking for?
Hi, Dr. Bennett.
Oh, is this Zanab?
Yes,
How you doing?
I'm good. How you doing?
Oh, okay. You're in Iraq.
Yes, from Iraq.
There's another Zanab from Africa here, from Guinea, Africa. Are you there, Zanab? The other Zanab. Welcome.
Welcome. Zina will join shortly.
Oh, okay. So we already have 4 Zainab in the meeting.
How's it structured today, Samer? What are you going to
do? So today we'll start a little bit about more in depth with the neurosurgery experience. So I will give them actually 2 presentations during the first hour. I'll try the first to be more interactive, and after this 1 hour, the same as the last time, we will go offline and we will discuss some questions. devices and cases.
How'd that go on Saturday? Did it go okay?
It's okay. It's not the easiest form, but I want that. You know,
Yeah.
even in the announcement for the meeting, I put it through a motivation letter through email, because
Okay.
with my experience, previous mentorships, the previous one maybe 500 attendee, but all go through just direct link. It's not controlled. I don't like it.
Well,
For
you
the
know, it's difficult to get people to change platforms. Once they leave one, you won't see many that follow.
yeah. So yeah, for
We
me
tried,
though,
we tried that because you know what we tried to have a Zoom lounge where I would say, okay, everyone, let's meet in this another room in a different, totally separate.
yeah,
It just didn't work. We tried, but it's best at the end. Well, I don't know. I'm still trying to find the best. But
yeah,
at the end, you say, okay, if you want to hang around and talk to the professor or the other med students, hang around and we'll just go offline. There. We try it
okay,
all. We try it all.
yeah. I understand that you have you have figured out the best way to work through
Yeah.
these, I don't know, thousands of meetings over the last few years.
Yeah,
Thousands, I
well,
think.
it's good. I'm not sick of them. I like them. They're to me, they're fun
Yeah,
because I'm
actually,
looking at it from a different viewpoint than you are. You know, I'm not listening to the science too much. I'm trying to get this organized, and
yeah,
it's going well. It's going very well. You've seen it grow. It's not going
yeah,
to be super. It's just slow and methodical, just like learning neurosurgery. You don't learn it overnight. You just got to get some experience and make mistakes. So, anyways, okay, let me know when you're ready to start.
yeah. But actually, it's super. Just to let you know, it's super efforts just to arrange all of this together.
I'm
We
sorry, I
are,
didn't understand what you said, Samer.
I mean, these efforts are super from you. We are lucky to have this dedication, and thank you.
Well, it's
This is
fun. It's
this is offline.
enjoyable.
Yeah,
Well,
and
you know, as a doctor, you feel better if you're helping people. As a doctor, I mean, that's a basic feeling, and
yeah,
that sometimes beats money. You know, so and I'm sure you understand that.
yeah, definitely. Yeah.
Yeah.
And
So
you are doing helping people.
yeah, this is great. This is great. I'm glad to see you have so many people following you. Man, it's a lot of people. 80 people now. Wow, that's great. Okay, so basically we'll introduce you and you just run the show
Yeah, okay.
whenever you're ready.
I'm ready.
Oh, okay, here we go. Okay, let me mute somebody there. Oh, can anybody hear me? I see a microphone open, but okay, anyways, okay. Here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach, home of Neurosurgical TV. We have the honor and pleasure of having Samer'S, MD, a neurosurgeon from Iraq, dedicated neurosurgery mentor. He's now currently in Cincinnati and continuing to mentor, and he's basically going to run the show. So I'll let him do his thing. Hello, Samer.
Hello, John. Hi, everybody. Thank you, John, for this opportunity. Thank you for the Neurosurgical TV to be this active platform for people from around the world. Yes, we are here to start the new session of our mentorship. Officially, it's the third session because we take an extra session on Sunday, and today We will go through some topics. I think today will be the videos day. I think we have many videos to share with you, and also to be ready to be interactive, because basically I will not put a video or picture without asking about it. That's the usual, let's say 80%. For those who are interested to be participating in the interactive session, just you need to raise your hand and we will involve you. Yeah, that will be better. Otherwise, I will select randomly, and this will be maybe embarrassing for some people. So I am just promoting some people that want to participate, and with that, I will start our talk.
This is different. This is different.
Yeah.
Yeah.
So yeah, so in general, today we will do the same as we did on last Saturday. We will start the first hour here to be recorded and documented on the Neurosurgical TV and to be shared in public. And the second part will be, I will send you a Zoom link through the Telegram group to join. I know it's not the easiest way, but this is the only way that I can protect the patient data, and I can share it in private meetings also. So I'm repeating that, but this is just to make it clear for everybody, and I hope you will enjoy the presentation today. So basically, I will share. I want to start with sharing some videos, and after this video, I want to ask a few people about just their impression. So if you see this video, is it moving now?
Yes.
Okay, so basically this is hydatid cyst of the brain. This is a space occupying lesion, large space occupying lesion. Very interesting cyst. It's a unique cyst that have a thick wall and thin wall at the same time. So it is thin when we are trying to dissect it from the brain, because we don't want this to rupture. And as you see, we try to get it out through a method. It's actually looks like a delivery method. So we push water, we push normal saline and the back of the cyst, then it will be delivered out of the brain. It's very unique technique, mostly used only for hydatid cyst, and you can see the end result. And at the same time, this is a thick wall enough to hold the fluid inside. The fluid is filled with the parasites and the contents from the parasite, and it's very toxic to the brain. And here it looks like an exact delivery. It's like Apgar score now, and you should be patient enough, and you should also wait for the pulsation of the brain to push the cyst out. That's one of the tricks. And here we are, and it's very a victorial moment when you have the full cyst out, because you do the full surgery waiting, or actually in a suspicion, or in because there is a high risk of rupture of the cyst, and this will be like a disastrous anaphylactic shock possibility. Another cyst, actually maybe very similar size and maybe from different angle, just to show you how it's hung to the brain and what's the role of the fluid that we push on the back to separate the cyst from the brain to obtain this delivery. So it's not a usual lesion, it's a rare lesion. However, it's very a different technique to do the surgery. And After that, I want to share the second video, which is a quite different story, but this is just to for brainstorming for all of us today. And this video is an actual video of my first aneurysm clipping surgery, my first ever surgery, my first ever official aneurysm surgery as a surgeon, as an attending. And this is summarized 20 minutes from the, the security cam and at the angle of the room. So this is not usual recording. I asked for that on purpose just to show you the following. I will put the speed in 5, or I put the speed on 10, because it's not about the exact steps, it's about to look around what's the dynamics inside the operative room. I think it's very rare for anybody of us to know exactly what happened unless we see this view from outside, that, oh, this is the surgical team. You can see around the head of the patient. There are 3 of them. One of them is me. And we are trying to alternate opening the craniotomy, opening the head. And you can notice the rotating nurses, how they are doing active job and arranging thing. And here it is. This is the operative microscope going inside. This means that we reach the brain now. And after opening the dura, we launch the microscope above the head and we start to do the microsurgical part of the procedure. And I don't think I need a lot of comments with this video. You just need to see it and maybe get back to the recording later and see it again. So the light's off and depend on only the light of microscope now, and you can see the recording on the wall with the screen on the wall. And I'm the surgeon here operating, and there is 2 assistant surgeons, 1 surgeon, 1 resident, and there is the operating nurse. He's handling all the instrument, and his role is very important. Also, there is another screen hangs in the center of the operative room for the anesthesia and for residents to follow, and for nurse to follow what happened. So if I put it on 30 for the last time, just to show you exactly what happened. And this is for basically for any cranial surgery, and I think it's similar in general for all surgeries, whether neurosurgery or not, but this is very exact example of brain surgery, microscopical surgery, and the details in it. So for you, I want you to think as a student, as a resident, that you will be part of this team. You should be very oriented in every step that you are doing. I want to have just a single or 2 comments here from the participant, and after the online session we can go through more responses or more opinion, because the idea is that your opinion, your understanding is very important at this point to for me as a feedback. Then from that I can explain more. So anybody of you have an opinion in mind about these 2 videos when he saw them? What do you think? If you are the surgeon, if you are, I don't know, if you are the administrator of hospital, what do you think about that? Okay, Omar.
Yeah, Omar.
Introduce yourself, please, and unmute first, then introduce yourself.
How are you, Doctor? I am Omar Adnan Taha, 6th year stage in Musansariya Medical College. I am very interested in neurosurgery, and I want in the future to be a good surgeon, inshallah.
Sure.
Okay.
What's what's your opinion? What you have in mind when you see the hydatid cyst evacuation from the brain?
My opinion is to ask you about the management if the hydatid cyst is ruptured. I don't know what we will do for it.
Yeah, that's basically a nightmare that can happen anytime you are operating on hydatid cyst. Basically, hydatid cyst is common in some parts of the world. It's not everywhere, but back in Iraq, it's common, and especially in the south area. And what we are doing when we have a rupture, there is multiple steps that you can go through, but basically for you just to summarize and to simplify is we treat it as an anaphylactic shock. So we give a hypertonic solution on the brain just to clear and kill the parasite that's spilled out of the cyst on the brain. And at the same time, we monitor the vital sign closely, and we give the patient steroid and fluids, IV fluids, just in case he develop a shock. And you should definitely clean all the
Doctor, the hypertonic saline, you means mannitol or anything else?
I don't want to go through these details now. We can go through it later because there is trends, there is schools, people can use different fluids, but this is one point I want to stress for you as a medical student is that when you are exploring a branch, a possible branch to be your future career in the maybe for you or for other people, and this is applicable for any branch, don't get it to the extra details because this specific question is very nice from you. The other part of the question, what's the exact fluid, for me looks like is a 6-year medical student question. Is someone thinking that I need to know all the details about this procedure? It's not there. If you get my point, if you want to be a surgeon, it's not about the details now, it's about the full understanding. As a surgeon, what are the tasks that I will have? Do you understand my point that there is a difference?
Yes.
Yeah, there is a difference between the scientific information that you will have. For me, it's not important at the initial step. Being deep in science, you can do it whether you are a neurosurgeon or not. But as a surgeon, as a medical student, you want to think yourself, maybe if I am a neurosurgeon, what I will do, or is the neurosurgery fit or for me or not? I'm trying to drag you to think in another way, surgeon-wise, rather than detail-wise. The basic answer for that is that we have a guideline all over the world, and the guideline will say that in this situation, do this, in this situation, do this. So using the guideline is the easiest part to do. However, the personality of surgeon and how you understand how you prepare yourself from now till you get to the neurosurgery, this is the most important. And seeing these scenarios together, you and me, for example, at this moment is very important to get this discussion, maybe other points, just to tell you that, wow, this is what we need if you want to be a neurosurgeon, so you can prepare yourself. And also for other people other than you, Omar, maybe you are deciding already about neurosurgery, for other people just to see if the neurosurgery, maybe this is good, but this is not for me. Maybe this is very nice to see, but it's not nice to be the surgeon at that moment.
We have a couple of questions, Samer. Tabarak, you want to go? Are you there, Tabarak?
Yeah.
Yes,
Just I want to thank you, Omar, and definitely keep your question, and we have extra Q&A session. I will answer all that. I will be happy to do.
Thank you.
Thank you. Yes.
Okay.
Hello, Doctor. Good evening.
Hello.
Do you hear me? Hello.
Yes, we
My
hear
name
you.
is Farek, and I'm a fourth-year medical student at the University of Baghdad. My question
Welcome.
is that, what I think see in the video of highlighted is that the highlighted was superficial in the brain, right? So we use this type of procedure where you said that we're depending on the pulse of the brain to push it away, right? My question here is that in case that the highlighted was deeper in the brain, what we were gonna do in this case? Because I think it's going to be a more invasive procedure, there were gonna be more complications and more difficult. So what is the solution in this case?
Yeah.
Thank you.
Thank you, Tabarak, for the answer. I will put it always in two part as a mentor, what I should say, and part as a source for you, what I should say. For a source, I will answer directly that for deep lesion, maybe the surgery is not the best option. That's as simple as that. If it's deep and small hydatid, you can continue on medical treatment with antiparasite, and that's it. That's the
Thank you.
answer. However,
Thank
and thank you for you. However, I will get this to extra point that, yeah, the decision is up to you as a surgeon. If you are, for example, Tabarak, in 10 years will be the full surgeon responsible for this patient, you will have that decision. So it's not said in the book that what's the exact size and what's the exact depth of the hydatid to do surgery or not. You get my point? And when you will have the knowledge will be the one that you will collect it from now. You will start from now. Just face the hydatid once. Let's see, once in OR, you will never forget it. That's why I will start with that video, because you will never forget this video of delivering that huge cyst from the brain. Actually, it's about third the size of the brain, maybe more. And from this moment, you will start collecting information with people. And once you focus more, you will get a huge experience. 10 years from now, let's say Tabarak, as a neurosurgeon, let's say in Iraq, and have a hydatid cyst, you will have the answer. It will be noted from the book that it depends on your skills. Some people afraid to go to deep hydatid cyst. Some people afraid to do surgery for very huge hydatid cyst, and it's not a negative thing. It's very positive that I know the size of hydatid is difficult for me. I never remove something like this. It's just easy to ask someone older than me or have more experience with that specific lesion, and yes, let's go together and remove it. Because at the end, the most important part is not removing or not. The most important part is the patient health, and you need all the effort put on the same direction to get the best result. So that's the second answer for you, Tabarak, is that, yeah, the team effort and the built up experience with the time, you will have the best experience when to do and when not. And in deep part, yeah, you can use the same procedure. You can use dissections, and you can use the delivery even for deeper part. Sometimes you have at least 40 hydatid cysts in the brain. It can occur. For the spine is usually small and multiple, and the difficult is to complete evacuation versus not. So it depends. But just to put a line at the end for your important question, is that's why when people, let's say here in US, they don't have hydatid cyst a lot, but when they face this, they will need your experience. And another way that when we operate on something specific, and let's say in Iraq, we have 3 common things different from other part of the world. We have a common hydatid cyst, and we have the TB very common, and we have the trauma, unfortunately. So that's why you need to document your cases and to publish them, and to publish them as your experience or your center experience for other people from around the world to understand more and to share experience. You get my point?
Yeah, thank you, doctor, for the explanation. Thank you so much.
You
Well,
are welcome.
Samer, it's really heating up. We got a lot of questions here. Okay, I guess Nicola's next. Nicola, can you go ahead?
Yes, I'm here. I'm Nicola. I'm a fifth-year medical student at the University of Foggia in Italy. And rather than a question, I wanted to comment on the videos that we just saw. And with regard to the first video, I think the most important thing that we saw is the patients needed to such an operation, because in both videos, sometimes it almost feels like the cyst is falling off, but it's not. And so you still need to put that extra water. So the really important thing, I think, is to maintain the concentration and be focused from the beginning to the end, because a rupture of the cyst at any given moment could result in catastrophic consequences for the patient. And for the aneurysms, I think it really shows how we should behave as doctors, and how important it is to work in a cooperative system, because you can be the best surgeon in the world, but everything becomes more difficult if you're not in a system that works. And everyone needs to do their job at the best of their possibilities, because we are all working towards the same goal, which is patient's health and safety.
Thank you, Nicola. It's well said. I totally agree with you. It's a very nice way of thinking. 2 words I have in mind. The first, the smile. That when we are evacuating a high data cyst, the same thing that you said. The only one that will never have everybody in the operating room is a little bit smiling or happy, waiting for that moment, except the surgeon involved, because the surgeon at maximum stress will be, and you get the point, and you describe it well, that yeah, it's a huge responsibility from A to Z. It's your responsibility, and you should focus throughout the process. And the other point is that you mentioned about the other video. Yes, it's the team spirit, but it's not the simplified team spirit. It's the team that you build. Sometimes you are obligated to build your team and to collaborate with others. So try to think of that operative video just to put it in your mind, and you should build your relation based on that. Just to make an example, if you are a physician, you don't need that exact team attitude throughout your career, because it's here, the information is here. If I need something, I need just to study this. But in surgery, you will never learn if the resident and the level higher than you have no good relationship with you. It's just simple as that. So you need to be in a good relation with all your superior, so they can support you and teach you. And at the same time, you should deal with each part of the neurosurgical team as to identify their importance, to keep them focused with you 100%, whether anesthesia, whether the staff and nurses, it's equally important. All the effort are the same. And thank you, Nicola, for your comment. I will take 2 more. Okay.
This is great, Samer. I'll tell you, we have 3 or 4 questions. We have Mariam Alawadi next. Mariam, you there?
Hello, good evening. Good evening, everyone. I'm Mariam Alawadi, MBCHB from Baghdad University College of Medicine, and I'm a lecturer in anatomy at College of Medicine, University of Ibn Sina. So I have a lot of questions about if we have another method or procedures that we can push out or deliver, as you said, Dr. Samer, deliver the cyst from the brain, or we are limited with the normal saline. There is another method rather than the normal saline, and we can use it.
Yeah, thank you, Mariam, for this brilliant question. Actually, Yeah, definitely. There is a lot of trials, and Dr. Abdelhadi Al-Khalili is one of the founder of Neurosurgery in Iraq, has invented an instrument. Actually, it's not getting there to be a full production, but the idea is the same as you are describing, that a method to suck the cyst rather than to pull it out of the brain, but it's in the same of your category of thinking that there should be another way. Other people try to puncture the cyst from inside, suck the content, and and put anti-parasite agent just to kill, to simplify the procedure. There is a trials, however, the official, or let's say the classic cyst, should be delivered in the way that you just see.
Thank you so much. Thank you.
Thank you. Thank you for your question. Yeah, Hussein Baban, and then Osama.
Good evening. Can you hear me, doctor?
Yes.
Yeah.
Hello, I'm Hussein Ali, 5th stage medical student at University of Baghdad. Doctor, regarding the second video, certainly it's a big stuff. Can you tell us more about their specialties? I mean, like, what specialties do you need to do a neurosurgery?
Thank you, Sam, for your question. Basically, we have 3 teams: the nurse and the staff team, which divided into 2: the part that operating with you and the part that bringing instrument. And this team 1. Team 2 is the anesthesia team, which includes the anesthetist as the specialist, and also anesthesia assistants, usually 1 or 2. They need to monitor the patient, and in this patient specific, they do a lumbar puncture and lumbar drain before the procedure, just to evacuate a few CCs, let's say 20 cc of CSF, prior I get to the brain, just to make the brain more relaxed for the procedure. So you can understand how important their part. And the third part is the surgical team, which include, for this surgery, for example, 2 surgeons and 1 resident. Thank you, Hassan, for your question. Let's go to Osama question.
Hello, everyone. My name is Osama Dalal, a 4th-year medical student at RCSI Bahrain. So my question is, are there any contraindications to the Dowling or Landau technique as displayed in the first video when removing the hydatid cyst?
Contraindication in, okay. Basically, I should put the line that from me, that I would not like to prefer to exactly answer the question in a deep scientific way, because it's not a inter-neurosurgeon discussion. That's a different point. Why? Because for surgical technique, it depends on your experience. That's the answer. So it's quite flexible with regard to indication and contraindication. It depends on your experience, especially with this very specific category of brain lesion. But for me, I don't see exact contraindication meaning here. If you have something in mind, can you put it an example? What do you think? Like, I mean, contraindication for what? For this surgery or for this specific technique?
For this, or like a brain cyst, specifically, or a deep-seated one.
Yeah, that's why I have an issue with the term contraindication, because it's indicated or not. When it's not indicated, this is not a contraindication. This is more to do a conservative treatment and see. It depends on how. Let's put it in 3 points just to simplify this and to be more specific for you. The growth of the cyst is the most important. When the cyst is growing with the following imaging and the patient has a symptom from it, so this is the typical indication for surgery, whatever the condition. We should go to surgery. And usually these lesions that increase and in size with the time, usually these are the more superficial lesion. It's obvious because they found a space, or they found a more compressible brain. This is number 1. Number 2, for For the deep lesion, I answered that before. What's the meaning of deep and what's the meaning of size? It depends on your experience. With the time, you will operate more deep and more large hydatid cyst. That's in general. And by the way, it's not for hydatid cyst. It's all for many brain lesion. It's also applicable, this rule, that you have the experience and to do such another level of surgery. And the third one, yeah, and there is a complex hydatid cyst, which is a different form when there is a multiple cyst inside the cyst. This will make the delivery is quite challenging because something related to dynamics of the cyst and how you can dissect it. It's sometimes difficult. And maybe I can add a factor is the adherence of the cyst to the brain. Usually if the cyst has a previous rupture intracranial or in another surgery before, it will be very adherent, difficult to control. So at that time, you will do a damage control surgery that you can you will evacuate the lesion that you can, and you will just partially remove and treat and wash the inaccessible lesion, let's say.
It's going crazy, Samer. There's 2 more questions. You want to take another one, or it's up to you?
Yeah, let's take them.
Okay, Ahmed Khalifa.
At the end is the student is their mentorship.
Hi,
Yeah, go Ahmed.
Hi, I'm Ahmed Khalil. I am in 3rd stage in University of Al-Amid. My question is, what happened?
And University of what? You need to go through the name, then the city, then the country, because it's quite variable.
At Karbala.
Okay, Baghdad, Iraq. Karbala, Iraq. Okay.
My question is, what happened if the surgeon make mistakes and the cyst is ruptured? What happened to the patient and how to clean?
Okay, so basically, if you ask this question when we are inside the surgery, you will be kicked out as a student. That, yeah, if you understand my point, Ahmed, that usually we don't ask these questions like when we are inside the surgery, we don't ask this question. If this rupture, if the patient stop his heart, oh, just be quiet, don't talk. But after the surgery, yeah, and after the surgery, yeah, we can have your question. As I said, there is a ladder of what to do. Basically, it's to evacuate whatever possible and wash the other part. That's as simple as that. Okay. And try to monitor the vital of patient, as I answered before. And just I want to simplify it. Today I'm obligated to post a paper describing the various available treatment for hydatid cyst and intraoperative rupture of hydatid cyst. Thank you for Ahmed for your question.
Thank you.
Yeah, Abdulaziz, you will be the last question. I will take other question later.
Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Abdulaziz Al-Ahmed from King Faisal University of Al-Ahsa, KSA. My question, Dr. Samer, is why we should remove it, like we should fill it first? Is it because the nature of the walls of the hydatid cyst, like the epidermoid cyst, or it is just a procedure to prevent the complication like rupture? Because what I think is that filling it is increase the chance of rupture, which is the nightmare of this procedure.
Yeah, I thank you, Abdulaziz, for your question. I need to show you something because, yeah, it can be seen as we are filling the cyst just to enlarge it and get it out. But in the reality, it's not that the exact procedure. What we do here is to push water between the cyst and the brain. That's it. We don't touch the cyst from any entry point. So we call it hydrodissection. It's used in many procedure around the medicine, and this is the hydrodissection, just to push a fluid between the brain and the cyst. Push a fluid, so you are creating a space, and with the pulsation of the brain, it will be pushed a little bit more and more. So we are pushing a fluid between the brain and the cyst to get the cyst outside. You get the point?
Okay.
Yeah, so that's the difference. And yeah, definitely, yeah, if we want to puncture it, so at least we can suck the content, and it will be quite risky. That some people try to do this, but I don't think there is any evidence that it's a safe procedure, as you said. Thank you, Abdulaziz, for your question.
No questions now, Samer.
Yeah, I see some questions on chat. I will skip them. Sorry, but I will ask Tiba and Mustafa just to write this question for later session. And I should say that I'm very thankful for your question, because that's the target that we are trying to think together. But I want you always to think as a surgeon rather than a student who want to answer some MCQs. And if you are ready, I will go to the presentation. Sorry, I shared it early. I hope I can get through both the presentation. I'll try to be more.
The students were alive today, Samer.
Sorry.
The students were alive.
Yeah, that's very important. That's why I keep listening to questions. I'm very happy with that response, because this means that somebody is get benefit, and yeah, I want them to be a surgeon better than me. That's the target. So try to be courageous enough. I want to volunteer for the next presentation, please. Best to be a new that I don't member of previous mentorships or so. So anybody interested? Jafar, are you new, Jafar? Yeah, I think, yeah, Jafar new. Jafar, Amar, Adnan, Hussein, I will take you, and Tabarak, I will take you all the four. That's it. Osama, let's keep you to the next presentation. I know you are well prepared. So with those, what we have now, Hussein, Omar, Tabarak. That's okay. Those the three. And you can unmute your speakers, please. Hussein, Omar, Adnan, and Tabarak Sabah. So you can answer directly without delay. And as the screen shared now. Do you see the screen?
No, Doctor.
How would you see the screen if I don't push the
there we go.
Screen sharing button?
There we
sorry.
go, yeah.
Yeah, sorry. Okay, so I want to see my screen, it's not full. So first, for those who don't know, I am a dual trained vascular neurosurgeon. This is a specific entity within neurosurgery, within vascular neurosurgery, that you can do open vascular surgery. At the same time, you have a specific training to do endovascular, mean catheterization. At the end, you can treat vascular disease of the brain in two ways. Either you open the skull and do the direct surgery, or through the vessel, like the cardiac procedure catheterization. It's similar, but we can treat the diseases also from inside. This is let's say a super specialty within neurosurgery, or subspecialty. We call it dual trained or hybrid vascular neurosurgeon. And because that's the perspective I talk with. I think I need to update this. I have two new mentors here from US. I will update it on the next lectures also. These are my mentors. They are maybe close mentor, maybe overseas mentors, but those that I really have a pivot in my career due to one touch of them, either a speech, either quote, either distant inspiration. I follow them. So I always put that in the beginning of any presentation, that we are not superior to them, but we are shamefully inferior to them if we do not advance beyond them. So thank you for all of them. Yeah, come on now, Omar, Tabarak, and Hussein. Can you describe this if I say that this is a CT scan of the brain, multiple section, just axial section? We will go through CT scan later. It's not test about CT scan, by the way. Just I want to figure out what's the mechanism of this injury.
Is a bullet? Yes, I think like that. Like
Omar said bullet, Tabarak said bullet, and Hussein disappear. What is it?
Doctor, I will describe the region, hypotenuse region, the parietal.
No, it's not a question about CT scan. As I told you, that the gray area is the brain, the white area is the bone, the skull, and there is something inside the brain. They describe it as a bullet. I agree with them, but there should be always another possibilities. Do you have another thing in mind, or do you agree with them?
I agree with them. There's this bullet. I agree.
I think I have another opinion.
Who's talking? Because I
it's me, Jafar. So I think
Jafar, yeah.
The panelist.
Yeah, I'm listening.
So, is it possible that the bullet creates such a space inside the brain that's just stays there, right there, doesn't really like collapse back into itself, because this, like, there's a space inside the brain, and it's like there's a long thing inside the brain tissue.
Okay,
not just
so basically your answer, the three of you, I will get it into true, because there is, as they describe bullet in general, it's a penetrating injury to the skull. It's obvious. Number one. Number two, this thing is a, what's the question? The question is that you put, Jafar, is that what's the content of this thing? Is if it's a bullet, usually generate bubble and air enter the brain, it's acceptable. But the question that put by Jafar, which is very logic, why the space is empty now? Because the dark, the clear black color in CT scan usually denote air as the same thing as outside. So if this air, what holds the brain from the air? Why there is a pulling of the brain if this is an air, just an air due to bullet? Do you have any idea, like four of you now? The second question, if for me, it's not bullet, mostly due to this fact that if it's a bullet, question one, where is the bullet? It's not there, and I will show you later why it's not there. And number two, if it's bullet, why it will leave this black space, or looks like a space. It's not a characteristic, it's not logic. Do you have any idea in mind?
Could it be a hollow tube, for example, a hollow tube of glass?
That's creative. That's creative, Jafar. I like that answer. Hollow tube. Okay. The question that I will ask you to against this is that if it's a hollow tube, how it enter the skull?
Doctor, it may be a knife kick.
A knife, maybe a knife. Yeah, there's a knife stab, then pull it, or there's still the knife is there. That's the question. If they pull the knife, so why the brain is shy from the space, not filling the space? The same as Jafar question. And if it's a knife, what is the knife? The metallic area, if it's bullet or knife, usually have shattering and a huge artifact in the CT scan due to metallic component, and it's not there. Any suggestion from the four of you before I go to the answer?
Doctor, could it be malformation? AV malformation?
Who's commenting? I don't, Hussein, maybe? This is
Yes,
the
sir.
sound. Yeah. It's a trauma, and to be fair with you, this is a setting of trauma. There is an injury.
Doctor, let us thinking, please.
Okay. 1, 2, 3, 4. Done.
Doctor, I think it's a pencil.
Who's talking?
Ahmed Khalil.
No, I'm asking for. I know why. Let's go. But yeah, why this is a pencil?
Because the tip is hypodense and the body is black like wood.
But would the pencil had the tip the same as the center of it? Is it the same or not?
Not.
Like what's this is a specific type of pencil, have a specific material only on the tip and the shaft is empty, or what?
No, the tip is BP and the body is from the wood.
Doctor, is there any possibility of having hemorrhage here? Like the polyps have been rupturing a vessel and the space left behind the polyp is occupied by the blood or something like that? Or air?
This is the hemorrhage. This is the effect of this object. This is the hemorrhage. And you can see also this is a bone, by the way. This area is very white, very homogeneous white, is a bone. I got back to Ahmed Khalil. You are correct. Definitely you are correct. However, I don't know the exact answer for your scenario. I will put it as your answer said. This is a vague injury. We have a child have a vague trauma with his colleague playing football just in one of yard by the family. They don't know why they have this wound. And we go do the CT scan that you see, then we go to the surgery. We have a rule in surgery. If we have anything penetrating the skull, we should not go and pull it, because you may have a hemorrhage deep and you cannot control it and you will lose your patient. So we do a puncture, we call it burr hole, around the injury site. Then circumferentially, we remove the bone by bone nibbler. Then we control the object from all sides, and at that moment, yeah, we can pull it with the surrounding bone, and we call it circumferential craniectomy. And this is more closer look. And as you said, Ahmed, yeah, this is a pencil. This is very rare, and it's cut pencil because it's not there from outside. And at that moment, you don't know if it's a good pencil that penetrates this thick skull of 12-year boy, because it's a thick part. This is not the orbit or the nose that you can enter the pencil easily. Or maybe the pencil is good, maybe the person is has a very hard hand. So we already published this, I think. Yeah, it's a published paper, and this is the post-op. We evacuate, we remove the pencil, we do a craniectomy on the side, we wash the area. There is some bleeding there, but it will go with time, because you don't need to evacuate every spot in the brain. You do just simple wash to the area, and we put a question on the end of that paper that what's the content of the pencil tip? Can be this toxic in the future or not? We don't know. The patient is good. However, this is just a scientific question for the future. If you have a question at this point, please keep it to the end because I want to go through more through the presentation. And thank you all of the four. I will continue with you. So basically we have our lab. We make it in 2015, and we have a very brilliant friend who's resident doing this architect for us, and this is very nice. We put the circle of Willis for the first time in any logo in neurosurgery. I mean, that was our thinking at that time, and we put the handle of microscope just to bring both ideas, and the eye of microscope and the more lab simulation, less brain complication. That's the motto. And we try from zero how to do drilling and bring just cheap microscope to try. Then we make another station for surgical loop, so the resident can compare the loop versus microscope, and the third one is for drilling. And we make a lot of courses. You can put your girlfriend name or whatever by your drilling, and this is just one of the, I think, the 7th or 8th course results. They put their names, and yeah, it was interesting to participate in whatever you can do. It's according to where you are, but it's just simple to have something animal model that's available in the market and try to do what's the bone, what's the brain, what's the dura. And at that time, at 2018, we have a good recognition from the head of World Federation of Neurosurgery, Professor Servedai. He put these pictures in the Malaysia meeting 2018, and for our lab as an example of a good teaching source with limited resources. So the idea is that I'm sharing this with you because it's doable everywhere if you want to do. Going to the next step. So for intracranial aneurysm, that's one of my favorite topic. Definitely, I will talk a lot about aneurysm every now and then. So it's just the normal vessel of the brain has a small blip, then enlarge, make like a bulge, and this bulge can rupture anytime and cause subarachnoid hemorrhage, and maybe 50% fatal in the first month. So one of the treatment option is to do a clipping. This is the surgical clipping of the aneurysm. Okay, and you can make it like this. And the other option is to do endovascular, as I described to you before, that through catheterization from the groin or from the hand, to go through inside the aneurysm and fill it with some specific coils. Both at the end result of both will prevent future bleeding. So this is just an example of one of my cases that we do. This is angiography of the patient. For the diagnosis, we fill the carotid artery with contrast, and this is the circulation, and this is obviously how large is the aneurysm. If you see the carotid artery here, the carotid artery is 4 millimeter width, so you can imagine how large this aneurysm for the brain. And also I put the post-op. In this case, we decide it's very large. It's not accessible for surgery easily. So we decide to put something inside the vessel through endovascular treatment called stent or flow diverting stent, just to put the stent there so the blood from the carotid go to the end of carotid without going to the aneurysm. So it's called a stenting. And this is the post-op image of it. You can see that the same carotid and the aneurysm is not there. This is just to give you an idea what we mean by endovascular treatment of aneurysm. And now I need the four of you, Amar Hussein and Tabarak, and I miss the fourth.
Yes.
Yeah. So basically, let's describe this for you as anatomy first. This is we open the skull from the left side. We go beneath the brain. So this is the optic nerve. Do you see it? Do you see my pointer?
Yes, doctor.
So this structure here is the optic nerve going to the orbit, and this structure here is the carotid entering the skull and going to the brain, and this is the brain. We pull it already by spatula. So here we pull the brain a little bit and go beneath the brain. Here the skull, here the brain, and between them you will see the neurovascular bundle. And this is the optic nerve again. This is the carotid. And here you can notice the bifurcation of carotid into something going medial to the hemisphere, which is the anterior cerebral artery. Do you see it, Omar? Do you see it, Tabarak? Try to memorize the name with me. It's carotid. This is anterior cerebral, and this is middle cerebral. And from the carotid, there is a branch called posterior communicating artery. If the aneurysm located this branch origin, we call it, this is aneurysm. Do you see the aneurysm? Well, is it clear? This is very large aneurysm originating from the carotid artery at the origin of posterior communicating, which we don't see now, and we call it posterior communicating artery aneurysm. So this is a left terminal approach to go to the posterior communicating artery aneurysm. Are you oriented now the structure that I said? I don't hear you, Omar. You are silent. I didn't hear you, Tabarak. I didn't.
Yes, doctor. Yes, I understand.
Okay. So we will go through the surgery and you will guide me. So you can see the CSF bulging, and you can see what we are doing is just to release the aneurysm from the deep part, because you want to put the clip as I show you with the pictures before. And we are trying to preserve any branch, which is here, just a little branch with a posterior communicating origin. And obviously for you as a medical student, one of the common questions for that is posterior communicating artery aneurysm can cause third nerve palsy because the third nerve will be there compressed. If you notice, I will go back to this. If you look to the aneurysm sac, and this is aneurysm neck. If you look to the aneurysm sac here, you can see the blood flow. Do you see the blood flow? How it's with the pulsation? It's very scary. It can rupture anytime. Basically, if you leave the rupture aneurysm, I mean ruptured, active rupture, the patient will die within a few minutes. So that's the level of stress that we have. And now we are trying to clip the neck of aneurysm. However, we don't clip it very close to the carotid because we will constrict the carotid. And do you notice the difference? I will go back just to show you pre and post clipping size of the aneurysm. You see the aneurysm size? And when we this is the neck. When we cut the blood supply from the neck through this clip, which is just designed for this is aneurysmal clip, you can see how small the aneurysm is and how adherent. So now we want to dissect the aneurysm. We want to check is the arteries are okay, is the clipping is complete. And now if you see the tip of aneurysm, there is adherent to the underlying structure. We know that this is the oculomotor nerve. This is the white area here. So now we are dissecting the aneurysm from the abducent because it's already compressing, the oculomotor, the third nerve. So because it's already compressing this nerve and the patient come with dilated pupil antosis. And now you can see how the aneurysm is now treated actually. And you can see you can change the focus and zoom during the procedure. This is using the microscope. And yeah, we are checking all the branches and we are seeing there is a branch going out from aneurysm. I want to preserve it. So I put another clip and then I remove the first clip just to try to make it better. You see how bulge the neck of aneurysm again? But now we are controlling the aneurysm because usually the aneurysm rupture at the tip. And now we bring a smaller clip just to clip most of the part of it. And now we will go through it. So now you can see there is what, oh, sorry. Okay. So if you see here, there's a residual of the aneurysm wall of the aneurysm cyst. We left it intentionally just to let the blood go to this branch because it looks like perforator going to the basal ganglia. That's why we do this extra procedure. Please don't ask me about it because it's just extra rare detail that we don't do it a lot. But let's get back to the whole picture. The aneurysm treated, the patient life is saved now. There's no possibility of rupture. This clips will stay for life in the patient. And now we call it overkill, that we go and cauterize the remaining part of aneurysm. And here we remove what we put already and go back. Bye-bye. So that's the end of procedure. This will stay in the brain for life. And with the time, there is no more blood enter the aneurysm because there is no more aneurysm. And this is definitely treated. And this is frontal lobe. This is the temporal lobe. And this is the sylvian fissure. And this is how we go inside. I will go to the next video where I will ask Amar and Tabarak Hussein for. So we have a similar case. This is the angiography. We have a swelling in the carotid wall, and this is aneurysm. We don't know if it's aneurysm or not just by looking to one picture. Usually rotate through all angle, and we have a patient already have subarachnoid hemorrhage. So we are looking for the source. And yeah, I want to ask you if this is the same side. Okay, this is left side. This is also terional. This is also become aneurysm. My question is for Amar, Hussein, Tabarak.
Yes.
Yes, sir.
And I missed one of you, the fourth one. Okay. What's this?
This is the optic.
Nerve?
The optic nerve.
Definitely optic nerve. Left or right, by the way?
You said that
Because,
this is was the left?
yeah.
Yeah. No,
left.
I think
This is the left optic. The right will be on the other side because we are coming from the side of the skull. We don't open from the front. And
yes.
The question for three of you again, what's this?
It should be the
Yes.
internal carotid at the level of bifurcation.
Internal carotid artery. Obviously, the bifurcation should be there, but I don't see
Yes.
it. Okay. And what will be this part of the brain?
Should gonna be the temporal or the
Or this should be the frontal because the frontal
Yeah.
above the eye and the optic going
Yeah.
to the eye, and this is the frontal, and this area should be something temporal, and this red area is the aneurysm.
It is smaller than the first one.
Smaller and ugly. The first one is very clear, very nice. That's why I start with it. The second one is that 50% of the cases you don't see an easy aneurysm. It's more difficult. And even it's not similar to the one that we already see in the angio. There's one bulge on the angiography. This is the CT angiography. If you compare it to here, this is the description: left optic, left ICA, and this is the aneurysm. Usually, actually, it's 2 or 3 bulging. It's different. Is there any meaning for this difference between the CT angiography of the patient versus when we go inside the brain? Do you have any idea in mind why it's different?
Perhaps it is because of clots.
That's interesting. Who's saying this?
Jaffer.
Oh, okay, Jaffer, the fourth one. Oh, okay. Okay, Jaffer, this is interesting. However, it's not not quite correct. So we have an aneurysm. Let's get me to the question. We have an aneurysm shape on the CTA. Let's say imaging before the surgery, there is a shape of aneurysm. When we go to the surgery, which is usually 24 hours later, we have a different shape of aneurysm. Is there, what's the possibility? It's not an easy question, but just I'm trying to let you think that, yeah, this is very, very risky thing to see, because this means that maybe this is a growth of aneurysm.
Tumor? Is there a tumor? Maybe a possibility for tumor?
No, like Tabarak, the tumor is not something scary more than aneurysm. It's down there. There is nothing scary. Rather, like if we have, I will show you, like in I think lecture 4 or 5, I will show you a case of tumor and aneurysm. The tumor is not that quite challenging as compared to aneurysm, because in an aneurysm there may be a rupture at any moment, and if rupture and if you don't control this rupture for a few minutes, the patient will die on table, and you cannot give blood or anything. This is not the surgery that they put it like how they decompose the settled bomb. I don't know how to say it in English, but when there is a bomb and there is a timer and you want to remove the things just to stop it, like the movies, it's the same for aneurysm surgery. So
our doctor says that intracranial aneurysm is with worse headache in his life before the diagnosis.
That's the typical presentation. The patient will describe, this is my worst headache of my life. This is the typical presentation, of rupture aneurysm when we have the rupture. Back again to the surgery. Let's focus again, and back to the 4.
Doctor, maybe it has to do with the blood flow.
I will not answer anything. I'm afraid of the aneurysm to rupture now.
I know. I mean about the difference between the imaging and the surgery.
Hassan, keep your comment, put it down, and I'm operating now. The same thing that will happen inside the surgery, that there is a timing for any. Okay, we have this discussion. Let's go complete the surgery, save the patient, then we can complete all the questions or all the suggestions. So we start at the same as the previous case, dissecting around the aneurysm. And can you expect what's the next step, what we will do? Amar, Tabara,
evacuating the fluid. Oh my God. Oh my God. This is it ruptured?
What do you think?
We need to control the source. Maybe bleeding.
I can't breathe really. We need to get out all of this blood.
First we need to keep calm. First, we need to keep calm and keep Tabarak quiet.
Yes.
Because that's the same inside surgery. There is a bleeding from somewhere. We don't know. It's coming from down, but I think this is because the aneurysm is directed posteriorly. So it ruptured on the back. And now you are looking to intraoperative rupture of aneurysm. I think this is one of the most difficult situation for any job, like in medicine in general. This is the most difficult situation that you will have. There is a rupture. If you notice, now let's get back to the surgery, what we will do. This hand showing the section device, it's not my hand, by the way. If you notice, I will go back so we can think again like a surgeon after this shock with the bleeding. So once there is a rupture, we have 2 section devices, one mine and the other is the assistant. So you need a good assistant. And now we are searching where is the point of rupture, where is the exact point. We are locating it. Okay, this is good. At least we see. Then I ask him, which is Dr. Haider Saleh. In this case, obviously, I put his name even before my name because he's the hero. And so he localized the point with the section device and give me the time to think. I'm thinking with my hand, and I ask the nurse, if you imagine with me, I want a clip now. I bring the clip. So and bring my two hands going to the aneurysm. I want to clip it. It's too wide. This is too wide aneurysm. I will tear the aneurysm if I clip it. So plan B, let's go to the ladder. Plan B, go and bring the golden clip. Do you see the difference? This clip is just golden in color because it's temporary clip. It's not very hard. So I block the blood from the origin, from the carotid origin. Then it's still bleeding. So I block from the other side also. So we call it trapping. So we block from both sides. Now there is a timer ticking that the anesthesia and the neurophysiology monitoring, counting the time. I have between up to 10 minutes, the usual. And we call this temporary clipping. Now we get back. If you see there is 3 hands, that's very important. I'm searching for any area that I can put the clip. And this is Dr. Haider's hand. And I think now you understand how important this. I bring another clip. I put it because I found some neck of aneurysm. That's the difference from the first case. This is very wide neck. It's clipped, but it's not good. Obviously, it's moved at the last moment. I can say this is not a tremor because it's the speed by 2 at least. And now it's clipped. Patient, okay, saved. Now I can talk. Before that, I cannot breathe at all. And I ask the anesthesia, is everything okay? Then I ask them, we have only 1.5 minutes from putting temporary clip. So we have more time. Let's go and confirm full dissection of the aneurysm, okay? Because maybe after I remove the golden clips, there is bleeding again because maybe the clip is not encircling the full aneurysm. And you can see the oculomotor nerve, by the way, is down. But now the major concern is the rupture. At this moment, this is not my hand, by the way. I put the second clip, I give the second clip to my assistant. That's the usual. And now you can see what we will do after clipping the aneurysm. Remove the distal first and see if everything okay or not. Then remove the first, and wow, that's the moment of victory. And we save the life, we clip the aneurysm, and we save our life, by the way. And it's difficult. And now you can see the aneurysm, sorry. Now you can see the carotid bifurcation down. After all this fight, it's there, the ACA and MCA. And here the clips, and we are going out. And this is blood due to subarachnoid hemorrhage. And this is the intraoperative monitoring data from our intraoperative monitoring neurophysiology. And they are showing that, I want to show you this, that there is a huge difference between it. First, there is the first one. This is the first one, 2-minute post-temporary clipping of ICA. Then there is a drop. There is a drop of signal, 7 minutes. Okay, there is a drop of signal returning, and okay, I missed something. Yeah, this is the first one. 2 minutes after I put the temporary clip, the upper limb, right upper limb signal, if you read it, it's decreased more than 50%. So this is alarming sign that patient will be paralyzed. Right upper limb is not working. Okay, but I cannot stop. And then later, 2 minutes after removal of the clip, there is beginning of improvement. Then 7 minutes later, everything returned to normal, returning to pre-clipping amplitude. Just to finish this story, This is the post-op CT scan. Let's tour up it. This is the post-op CT scan showing, this is the clip, and that's it. Everything is normal. This black area is air. I will describe CT scan later so we can understand more what's normal. And this is how I put it. For me, in Iraq back, I put it on the YouTube channel on the same day. I give it the link to the patient. I say that you can share with whatever you want, and you can see many surgeon resident, and you can see here what I said, medical students. 1, 2, 3, 4, 5, 6, 7 medical students in this surgery. Okay, and this is just a full document for them that they attend. By saying this, I will go. Keep your questions, please, because we will need them. And I would just want to complete the presentation. It's just to share the full experience that this is like an example. Now we understand a little bit about aneurysm. So this is the aneurysm, this is the post clipping, how it will appear. And the most important, when you have a patient can die at any time and now have 4 full kids, and this is just after the surgery, it's a patient back to full normal. That's the beauty of vascular neurosurgery, because it's a vascular variation. So when you treat it, patient is back 100% normal. Maybe that's the advantage over the malignant tumor, because for malignant tumor you treat it, then at the end he will die. That's a huge difference. And getting person back to normal is a job satisfaction that I can say is difficult to attain in many jobs in your life ever. So this is just another example, like this anterior communicating artery, and it's clipped perfectly. However, there is a vasospasm, which is a common phenomenon, can occur after aneurysm, not very common, but can occur. And the patient post-op have a grade 0 weakness. And this is just part of one of the TV shows that we did at that time. And 3 months after the surgery, the patient is just coming to say hi. I didn't know the patient at all. Like, whoa, how grade 0 post-op? Grade 0 mean total paralysis. Go to 3 months. The answer is that this is vascular malformation. When you treat it, everything will get to normal in a high possibility. Not every patient have weakness will get back normal, but for me, up to 90% or more, they will get, they will, even they are totally paralyzed after aneurysm surgery. I think 1 out of 200 patients have still some significant paralysis. Otherwise, they are all improving, and that's very important. And I didn't read this in any of our texts. I mean, this is the experience that when you feel this, you will get the satisfaction. All of this is not an accomplishment. It's just part of your work. But for sure, this is the part that make you study more and be honest more, and to be happy with every day of your life more, because you are making a difference. The issue is that you need to be fully prepared before doing this procedure. This is like skydiving. You cannot try it twice. Oh, this time I cannot clip the full aneurysm. This is not like tumor. For tumor, you can remove part of it. You are not very efficient. But for aneurysm, either you clip it or you may lose the patient. That's the challenge. For this part of the presentation, my personal motto is that you are the most important. What we are doing now for me as a person is as equal, as important as getting that patient normal to life, because you are the future generation. And as we described, this is all done by team. And thank you. What's the time? Oops. Okay. I have another presentation already, but let's have first, John, are you here?
Yes, yes, very good.
Do we have a time, or you?
Yeah, we have plenty of time. Don't worry about it.
Okay, at least
it's
let's
great to see a good session. This is a good session.
Thank you. Let's take 10 minutes more for a question. Then we can go offline for more discussions. Okay. So basically, I would ask the 4 volunteer, because they volunteer their time and they have the courage, just to give me what's your feeling now, because I think a little bit we are doing the surgery together.
I think I can breathe now. I can take a breathe after receiving him. Yeah, it's a good feeling. But at first it was the worst feeling.
Yeah, it's not always.
Honestly, Doctor, honestly, it's amazing.
You're welcome. It's not all the time like this. I cannot ensure, but I think many people here already attend many surgeries with us. It's 90% it's going like this because you are doing in a perfect way. However, 10% there is a huge challenge and sometimes not solved. Even in those moments, you should fight to the last moment. What I'm proud of, that even in a country like Iraq, after operating 270 plus major surgery like this, I have no problem with the patient at all. And even the patient who are died eventually, which include like from 270, it's about 17 patients died at the end. Their family appreciate our effort till today. That's because basically you fight for that and you keep with the standard. What I want to say before taking another question, having a team, by a real team like Dr. Haider Saleh, which is a neurosurgeon like me, doing all the surgeries together and from zero, and he didn't train anywhere outside Iraq. I have a training in many countries and long training in Japan, but for Dr. Haider, he never trained outside. And we work together basically until after maybe 40 surgery, he can do the full surgery and I am the assistant. And for those attending our surgery last year, we have 5 surgeons. I am one of 5. All of them can do this surgery from zero. No, I don't have a mentor inside my hospital teaching me how to do aneurysm surgery. However, they are teaching us the appropriate craniotomy, the appropriate surgery, how to learn, and then you can take the next step. That's a huge point, just to put it in your mind that you are seeing this, but I'm expecting from Jafar, from Omar, from Tabarak, from Abdulaziz to get it to the next step. And I will be happy to support through the way, not for me only. I think everyone that can see there is a future generation oriented and they know what to do, they will support you. Yes, Jafar.
First of all, to comment on the videos on surgery, well done, amazing work, really. Myself, I'm not a big fan of vascular surgery. I used not to be a big fan of vascular surgery because of how complicated the surgical field and bloody it could have been. But there's a rule in vascular surgery. It is that you have to control the bleeding before you attempt, and the control of bleeding in that particular surgery, the video you showed us, doctor, was astonishing. It was very, very beautifully done. Now I can say I do happen to like vascular surgery.
And vascular surgery send you like also. Thank you. Yeah, thank you, Jafar, for your comment. Yes, Omar.
Doctor, can I ask you about borehole and craniectomy? When we need to do borehole and when we need to do craniectomy?
Okay, can I skip a question to the end?
Okay.
Because I need to teach you why I will skip this answer. Just not because this is not for you. This is for all the attendees here. the timing of everything. After we attend such video, we are expecting to discuss about it. When you bring an out of the box question, it is out of the box. It's nice. However, the timing is very important. So I will be happy to answer it at the end, but not after this experience. Okay, do you get the point? I'm not commenting on you personally, definitely, but we are trying to learn together, because this is very important. This is even important than the exact science, because this will get you. I want you to be the best in discussing things in the future in any conference, and this is the start to have the discussion on every step, even the simple comment, even the simple question, how to comment, how to question. There is always a different opinion. Now, with the title of mentorship, I have a little bit of authority to comment on this. You get my point?
Yes,
if we are not in a mentorship, I cannot say, Omar, this is not the good time for a question. No, this is not the right thing. But from a mentorship point of view, yeah, Omar, try to, because you are part of very a specific event. When we are opening the comment, it's not, by the way, it's not mandatory to give a question. I always talk to the student like this. If you are giving a presentation, let's say, Omar, I can bet that we can do a presentation at the 9th meeting, and I can prepare with you from now. You will give the presentation. Okay. After you will give the presentation, remember these words that I will say now, that you will be want anything except a question. But it's not there. There should be some question. However, try to be the one that say, after your presentation, I will comment and say, okay, Omar, thank you for your work. I like this and this in your presentation. Then after that, I will deliver a question in as simplest way possible. Like, and what do you think about something? That's the better idea. That's the more professional thing. And if you do things professional when you are young, that will be a great advantage for you. For me, that will be the advantage of Omar with orientation and mentorship, and Omar without. Do you get my point?
Yes.
That's very important. And thank you for accepting that, because this is very teaching for everybody.
Okay.
Thank you. What we have, do we get Tabarak? I listened to Tabarak a little bit, just cry, then laugh, then disappear.
Hello, Doctor. Yeah, I'm really proud of your work and the work of Dr. Haider. This is really an astonishing thing. And this made me also thinking about how much I need to work on myself to, as much as possible, to prevent such a complications, and also developing my personality to keep calm and deal with the condition that I'm facing. So it's really amazing work. Thank you so much, Doctor. Thank you.
Thank you for your comment. What I should say as an answer, that think again that you are maybe in the 4th year of your medical school, seeing this, and for me, who are doing this, I see it for the first time. My first aneurysm surgery is in the 4th year of my residency. So you already have the advantage to do better and think in this way, especially when we are here and we are ready to help you.
Yes,
thank you. Thank you. Yeah, Abdulaziz.
First of all, Doctor, thank you for showing us this great procedure. Actually, I have attended a lot of procedures like skull base, pediatric, and also functional in our neurological center in Riyadh. But like this, for vascular, now I have realized that I cannot accommodate this type of procedure. It's really, really stressful, not like spine or skull base. So thank you for this experience.
Thank you, Abdulaziz. I cannot comment a lot your comment online. I can comment offline because it involves any other specialties. But yeah, definitely the stress level is the highest in vascular for me. And if you will see on the next session, I will present an AVM surgery of 12 hours. And you will have this in mind that this is a neurosurgery. However, doing a spine surgery is totally different from oncology, totally different from, as you said, functional, pediatric, vascular. Each of them has a different mindset and ability within the neurosurgery. And one of the target of such mentorships is to get the early exposure for medical students that, hey, just to remember you, that just to make it noticeable that not every neurosurgery is a neurosurgery. It's a totally different setting and variation inside. However, the training almost the first 4 years everywhere in the world is the same, because you need to manage the urgent thing, whether cranial or spinal. But after that, even your personality will be like, if you see a personality of a specific subspecialty, it will be totally different from the other. But in general, the vascular is usually require a huge courage, that courage and patience. It's difficult to collaborate at the same time, and that's why you will be very happy with the result of the patient at the end, because it's a real challenge. I am biased. I'm definitely biased. I cannot make you love oncology when I am only vascular surgeons, because, by the way, many surgeons, like I could say 80% of the neurosurgeons around the world doing general neurosurgery with a little interest or with a more interest on a specific category of surgeries. But for me, as my personal experience is totally different. I cannot do anything except vascular, open or an endo. For me, I'm not doing any spine. Even in the last year of residency, I quit doing spine. That's a total early decision, maybe aggressive, maybe extreme decision. I do not advise in this way, but just to give you an idea that I am biased, by the way. And thank you for your question, Abdulaziz. Yeah, Osama.
First of all, thank you so much, Dr. Hud, for the video. And like, I honestly found it very stressful, and like I found myself like holding my breath with all the adrenaline.
That's very good. That you have the focus.
So like, I started to share a sentiment with one of my colleagues earlier when he mentioned that he started to have like a newfound interest and passion for vascular neurosurgery. So my question is, in what cases would you do coiling, and what cases would you do clipping?
The official answer is that it depends on the aneurysm size and shape. The correct answer is depend on at least 10 factors. One of them is the availability of endovascular. One of them is the, let's say, the economic status of the patient. It's very different setting. I think I will go through this in one of the next lectures, because we have a case and I will ask you to do clip or coil, and we will go through either scenario and we will go through the steps, because it's more than indication. If you search now in the box, what's the indication of clipping versus coiling, the answer will be wide neck aneurysm is best for clipping, while narrow neck aneurysm is best for coiling. Okay, but this is outdated. This is just expire answer. But for you in your exam, in your residency exam, you will answer like this. But it's expired. There is at least 10 different device new already used for 10 years for wide neck aneurysm, and they are endovascular devices. So it's not there. Like, there is more complex process through it. I will try to simplify just to, I want to give you the factors. What are the answer? What are the factors that will make me choose this versus this? Especially when we have this advantage that you can do both. That's one of the advantage that of the hybrid neurosurgeon, and that's what I learned from Japan, that both, you can do coiling, you can do clipping, so the decision will be 100% based on the patient. Okay, sometimes it's not there. First, like my first year, actually my first 2 years, I don't have endovascular at all. So I know I have no endovascular option to offer for the patient. So either clipping or clipping. Do you get my point?
Yes, thank you so much, Dr. Hood.
You're welcome, especially if you add that we are talking about aneurysm rupture, seborrheic hemorrhage that usually are not allowed to travel. Because travel, there is a huge risk, especially if it's an airplane travel. You get my point? So the patient, you and the patient will be obligated to do some choices. It depends on the availability, on the standard. And by the way, now around the world, just to inform you on updated information, that now around the world, there is no 100% agreement about which treatment for which type of aneurysm. It depends on the institution. I know many institute, one of the largest institute or two of the largest, they are doing in different way. So that's how it's deep, and it depends on many factors. Out of the factors, thank you, Osama. Amar, if you holding your hand for another question, or you just forget your hand?
No,
Zainab?
no, Dr.
Yeah, I know. Zainab Talib?
Hello, everyone. I am Zainab Talib, medical student at Al Qadsiya University. First of all, I would like to thank you, Doctor.
In Iraq?
Yes, in Iraq.
Okay.
I want to thank you, Doctor, to have this opportunity to bring this amazing Zoom interview. I would ask you a question. If you have a lab and scans for the patient with aneurysm, let's say on Thursday, and you run the pre-op scans and the aneurysm size is changed. So how you prepare you and yourself, you and your patient for the surgery? It's the risk is increased, or this is just how aneurysm pass? It's grow in size, or it's have just one size?
Okay. 2 points. First, I will send you back to the comment about Omar. If you want to ask, keep it simple, one line, no more than one line. Otherwise, we get lost. I understand your point, but we all get lost. We can say, you can try to put it in another way, just simple for me and for others.
Thank you, doctors.
Like you can say, if there is a growth, what you will do. That's simply your question.
Yes.
Yeah.
Yes.
But you are like you're holding your ear in the opposite way. So that's why I comment on Omar, and I told Omar, this is not for you. This is universal that you are trying. And by the way, this is not only for students. Some conferences, the person who want to ask try to say that I know a lot about this topic also within the question, and this will be the end. There will be a very long question based on the we just get lost. So if there is a growth, I will just hurry up inside the surgery. It will increase the urgency of surgery. That's the answer.
Yes.
However, in this case, we don't know about the growth until intra-op.
Yes, you mean neurosurgery, it's surprise on the table.
I like the dedication and the like concern about the details will minimize the surprises, because the surprises means something very bad for me as a surgeon. If you get to my position, you will understand what I say, that you will minimize the surprises as much as possible. However, just to put it in your mind that we don't need to do another imaging for the patient if there is no indication. So because there is a risk with any imaging, there is this CT angio, there is contrast and there is contrast. Injury to the kidney, there is a risk with any procedure. There is no zero risk procedure.
Yes.
But this creates the issue. For me, I put it as a star. I will ask Mustafa to add this specific comment as a paper, the growth of the aneurysm, and we will involve you in the writing process.
Thank you, doctor.
Thank you. Because you give us the idea, you highlight some specific point. Yeah.
Thank you so much.
You're welcome. Hussein, do you have?
Hello, thanks a lot, doctor, for this opportunity. You really seem to be prepared for this surgery. So I wanted to ask, do some surgeons, like, for example, take beta blocker in case their hands shake, tremor, in such stressful situation? Is that a thing?
That's a very important question. I have been asked about this a lot, especially from students, that I have a tremor. Can I do neurosurgery? For me, I have a tremor before neurosurgery. And just simple, there is many steps that you can minimize the tremor. And at the end, I don't remember that I'm thinking about tremor inside the procedure at all. I told the student, the resident with me, that if you see my hand, you can figure some tremor, but if you see my hand inside the surgery, you will not see any tremor, because that's how you will handle during training. So the key is the training. That's why I will show you some steps of my training in India or in Baghdad, or how I train myself. It's not the typical, but as we always say, that we are here to share experience. So I work on my hand a lot with the time. Once I want to, let's say, to do a micro suturing, it's just very easy because of the training. So I don't need to go to search and the tremor will happen. No, it's just an easy thing to do. And that's, I think this is the answer, that the training will get you ready, not only for the tremor, for many things, that some people are just not patient, that, wow, like we have 14-hour AVM surgery. And at the end, like, students said, oh, I will never do something in my life for 14 hours, whatever, even gaming play, it's too much for me. And yeah, I understand his point, but I told him that, yeah, but you don't choose this situation. And this is part of your surgery. And sometimes that's what you get to think of neurosurgery, because usually people go to neurosurgery, those are high IQ. There is a debate about IQ, but the most important is that they are seeking a challenge. And here we are, the typical challenge that you will have, life or death situation, and it depends 100% on your hand in most of the instances, and the other percent is depend on your collaboration with others. Thank you. Do we have any comment before let's close the session, just to keep it? I don't want, because
two more. Zanab, do you have another comment? Zanab or Jaffer?
No, I think they forget their hand.
Oh, okay.
Yeah. Okay. Let's conclude this session. I have another presentation for 30 minutes. I think it's similar to, in a way, to this, with the type of question that can raise, but it's total different setting. It's about imaging and many cases with videos. So I'm satisfied with this part. Just make it continuous. And what I want now, just to conclude, to thank you for participation, and we can go to the extra session to have your question. If one of you is too busy, go with your work. Otherwise, we will have some discussion advices, and actually I have some quizzes that I want to ask, but usually offline. Thank you, everybody. Thank you for participation, and thank you for your time, and thank you, John, for having us.
Okay, one thing before leaving, Zoom is a surgical tool. Use it. Use it and learn to use it. Thank you.
Okay, thank you. So then the next meeting will be on Saturday, same time.
Very good. Thank you, everybody.
Okay, thank you. Bye-bye.
Yeah, I'm just stopping recording now.
Yeah, I should go.